The natural history of malaria involves cyclical infection of humans and female Anopheles mosquitoes. In humans, the parasites grow and multiply first in the liver cells and then in the red cells of the blood. In the blood, successive broods of parasites grow inside the red cells and destroy them, releasing daughter parasites, merozoites, that continue the cycle by invading other red cells. The blood-stage parasites are those that cause the symptoms of malaria. When certain forms of blood-stage parasites, gametocytes, which occur in male and female forms, are ingested during blood feeding by a female Anopheles mosquito, they mate in the gut of the mosquito and begin a cycle of growth and multiplication in the mosquito. After 10 to 18 days, a form of the parasite, called a sporozoite, migrates to the mosquito's salivary glands. When the Anopheles mosquito takes a blood meal on another human, anticoagulant saliva is injected together with the sporozoites, which migrate to the liver, thereby beginning a new cycle. Thus the infected mosquito carries the disease from one human to another, acting as a vector, while infected humans transmit the parasite to the mosquito. In contrast to the human host, the mosquito vector does not suffer from the presence of the parasites. The malaria parasite life cycle involves two hosts. During a blood meal, a malaria-infected female Anopheles mosquito inoculates sporozoites into the human host. Sporozoites infect liver cells and mature into schizoites, which rupture and release merozoites. Of note, in P. vivax and P. ovale, a dormant stage, hypnozoites can persist in the liver, if untreated, and cause relapses by invading the bloodstream weeks, or even years later. After this initial replication in the liver, exoerythrocytic schizogony, the parasites undergo asexual multiplication in the erythrocytes, erythrocytic schizogony. Merozoites infect red blood cells. The ring-stage trophozoites mature into schizoites, which rupture releasing merozoites. Some parasites differentiate into sexual erythrocytic stages, gametocytes. Blood-stage parasites are responsible for the clinical manifestations of the disease. The gametocytes, male microgametocytes, and female macrogametocytes, are ingested by an Anopheles mosquito during a blood meal. The parasite's multiplication in the mosquito is known as the sporogonic cycle. While in the mosquito's stomach, the microgametes penetrate the macrogametes, generating zygotes. The zygotes in turn become motile and elongated eukaryotes, which invade the midgut wall of the mosquito, where they develop into oocysts. The oocysts grow, rupture, and release sporozoites, which make their way to the mosquito's salivary glands. Inoculation of the sporozoites into a new human host perpetuates the malaria life cycle. Sexual erythrocytic stages, gametocytes. Blood stage parasites are responsible for the clinical manifestations of the disease. The gametocytes, male microgametocytes, and female macrogametocytes, are ingested by an Anopheles mosquito during a blood meal. The parasite's multiplication in the mosquito is known as the sporogonic cycle. While in the mosquito's stomach, the microgametes penetrate the macrogametes, generating zygotes. The zygotes in turn become motile and elongated eukaryotes, which invade the midgut wall of the mosquito, where they develop into oocysts. The oocysts grow, rupture, and release sporozoites, which make their way to the mosquito's salivary glands. Inoculation of the sporozoites into a new human host perpetuates the malaria life cycle. Malaria is an acute febrile illness. In a non-immune individual, symptoms usually appear 10 to 15 days after the infective mosquito bite. The first symptoms, fever, headache, and chills, may be mild and difficult to recognize as malaria. If not treated within 24 hours, Plasmodium falciparum malaria can progress to severe illness and lead to death. Children with severe malaria frequently develop one or more of the following symptoms: severe anemia, respiratory distress in relation to metabolic acidosis, or cerebral malaria. In adults, multi-organ failure is also frequent. In malaria endemic areas, people may develop partial immunity, allowing asymptomatic infections to occur. Some population groups are at considerably higher risk of contracting malaria and developing severe disease than others. These include infants, children under 5 years of age, pregnant women and patients with HIV/AIDS, as well as non-immune migrants, mobile populations, and travelers. National malaria control programs need to take special measures to protect these population groups from malaria infection, taking into consideration their specific circumstances. Malaria is a preventable and treatable disease. Early diagnosis and treatment of malaria reduces disease and prevents deaths, and also contributes to reducing transmission. The best available treatment, particularly for Plasmodium falciparum malaria, is artemisinin-based combination therapy, ACT. Antimalarial medicines can also be used to prevent malaria. For travelers, malaria can be prevented through chemoprophylaxis, which suppresses the blood stage of malaria infections, thereby preventing malaria disease. Prior to their travel to malaria-endemic countries or regions, individuals should consult their national disease control centers or other institutions offering travel advice for information regarding the preventive measures that should be taken.